Hello, everyone, and welcome to the UHN Foundation's third virtual speaker series on movement disorders. I'm Christian Coté, host of the UHN podcast, Behind the Breakthrough. Now, as many of you may recall, back in last April, the Toronto General and Western Hospital Foundation amalgamated with the Toronto Rehab Foundation to become UHN Foundation. So we welcome our repeat and new viewers to the UHN Foundation community. And we're grateful to all of you who are our family of supporters out there. We also want to give special thanks to Mr. Fraser Barrow. This speaker series has been made possible thanks to his remarkable generosity. So to Mr. Barrow, we are very thankful for your contribution and continued support. Today, we're discussing groundbreaking new research into relieving the pain of Parkinson's disease. Pain afflicts as many as 10% of people with Parkinson's, and most cannot tolerate the sleepiness and confusion regular pain medication induce. That's where an investigational study into the benefit of oils made from cannabinoids now comes in. Those oils are the active compounds in marijuana and are known as CBD for short. This pioneering study is led by today's key presenter, Dr. Susan Fox. She's Associate Director of the Edmund J. Safra Program in Parkinson's disease and the Morton and Gloria Shulman Movement Disorders Clinic. Welcome, Dr. Fox. You're there, right?
Hello, everybody.
Thanks, Dr. Fox. And as always, for our movement disorders speaker series, we're joined by Dr. Anthony Lang. He's director of the Edmund J. Safra Program in Parkinson's disease, the Morton and Gloria Shulman Movement Disorders Clinic, and the Rossi Progressive Nuclear Palsy Center. Welcome, Dr. Lang.
Hi, Christian. Hi, everybody.
We want to also involve you, the audience, in today's discussion. So as you're watching the live stream and you hear from Dr. Fox and Dr. Lang, if a question comes to mind, please send it in by going to the Slido page. You should see a link at the bottom of your screen right now, hopefully, and click on that Slido link, submit a question, or you can also vote on questions you would like answered. Sorry. Please keep in mind, for privacy reasons, we won't be able to field anything of a personal nature, and we'll be focusing on your questions a little later in the program. Okay, to Dr. Lang, let's start with you and the Morton and Gloria Shulman Movement Disorders Clinic. We've been through more than 19 months of the COVID-19 pandemic. Dr. Lang, talk to us about the adjustments you've had to make in the clinic to be able to continue serving and supporting patients.
Okay, well, I'm going to share my screen if you don't mind, and just remind everybody, can everybody see that? These speaker series come from our Movement Disorders Clinic at the Krembil Brain Institute. So we've got lots of names attached to us. You've heard the Edmund J. Safra Program in Parkinson's and the Rossi PSP Program and the Morton and Gloria Shulman Movement Disorders Clinic. So all of these apply to what we do. And who we are is this group of people. And we've been very proud to be presenting these speaker series for quite a long time. This is the third virtual, but we've been doing them live and hope to return to doing them live when COVID begins to end. Or hopefully we are beginning to end, but we're not ending. And so when it ends. As Christian's indicated, we've been dealing, as with everyone in healthcare, been dealing with tremendous challenges based on the threats that COVID had provided. We initially had to close the clinic and then very gradually developed virtual care, and this was done throughout the world. And we've really learned a great deal about virtual care, how it's possible to provide that care virtually. And I think this is a very, very important aspect of what will be part of your care going forward. We recognize that coming to a downtown Toronto hospital is inconvenient, it's costly both in terms of the time you spend, as well as the expense in paying for gas and parking and all the rest. And we really would like to do it in a way that's much more convenient for both you and the caregivers. On the other hand, I don't want to underestimate the importance of the personal connection that we all feel with our patients. And so I think putting virtual care that we've been providing and the challenges that COVID's created, putting that into perspective with good clinical care that I think will definitely continue to include live, hands-on, touchy-feely connections with our patients. We like our patients, we enjoy our communications and contacts, and I think they really provide us an important opportunity to get to know you better and for you to get to know each of us. Now, quickly, who is each of us? Well, this is the list of the movement disorders faculty who many of you have as your caregivers in our clinic. And each of them has not only a tremendous ability to care for patients with the diseases we manage, but they also conduct research in many, many different fields. And so each of them have been presenting at these speaker series regularly. And we're very fortunate today to have our associate director of the clinic, Dr. Susan Fox, who's a PhD neuropharmacologist. We have the advantage of having Susan present to us on her really groundbreaking work in the use of CBD oil in the management of pain and Parkinson's. So I'm going to pass it on to Dr. Fox. She knows everything that's going on in our clinic. So if I am not able to get back for the question and answer period, Dr. Fox will be more than capable of answering all your questions. So take it away. Christian, back to Dr. Fox. I'm not sure which direction you're going to go. And thank you, everybody, for your participation, your support of our clinic, which is invaluable. We can't do anything that we do without you. And we look forward to Dr. Fox's presentation.
Terrific. Thank you, Tony. Over to you, Dr. Fox.
Thank you very much. I will now share my screen and hopefully everyone can see that okay. Okay, wonderful. All right, so thank you again for asking me to present today. So I'm going to give you an overview of cannabis in Parkinson's and then lead on to this trial that you heard about related to pain in Parkinson's that we're now conducting here. So if I can advance now, there we go. So what is cannabis? Well, it's a chemical, a product that's been around for centuries for medicinal purposes, and many people have used it for pain in the past, including Queen Victoria famously used it to help her pain, and epileptic seizures is another use that it's been prescribed or used for. The current legalization of for personal use in Canada has increased our interest, both the lay and the medical interests. The problem, though, that we really face is that there is limited evidence and there are many myths surrounding the use of cannabis. And so what I want to do today is give you a little bit of a background on some of the evidence and some areas where we don't have evidence, where we're still needing to do further research. The challenge that we have with cannabis is it's a very complicated structure. The pharmacology is complex. So the plant Cannabis sativa contains over 100 pharmacologically active compounds. So it's not just one compound. And this is where it becomes very challenging to prescribe and know the type of dose, the type of preparation that people should have. Many of you are probably aware of the word THC. So this is what we call the psychoactive component of cannabis. And this is what gives people that high euphoric feeling and a reason that sometimes people take cannabis. The other most prevalent component of cannabis sativa is cannabidiol or CBD, which is actually the non-psychoactive component of cannabinoid, and this can have a sedating, analgesic, so pain relieving property. But on top of that, there are many, many other components of the plant itself. And so the problem is when people take cannabis sativa, we don't really know which of these components is actually helping them or causing side effects if they're trying to alleviate, say, a specific medical problem. The interesting thing about cannabis is that we actually have it in our brain and body. So it's actually a natural product, and it's called an endocannabinoid. And endo means it's within the body. And there are a number of these, but the most prevalent are the ones that I've listed here on the left. So anandamide, or abbreviated to AEA, was the first endogenous cannabinoid to be described. And the word anandamide is actually Sanskrit for bliss. And that's obviously some of the feelings people get when they inhale and smoke or ingest cannabis. And then the other one is called 2-AG. It's got a very long, complicated chemical name. And these endogenous cannabinoids work in the brain in the same way as other chemicals. They have receptors, so they bind to a receptor, they activate the receptor, and they cause a change in a nerve or a cell membrane function. And so they work in a very similar way to other chemicals in the brain. For example, dopamine, which all of you who have Parkinson's are aware of, is the principal chemical involved in Parkinson's disease. So endocannabinoids are, if you like, similar to dopamine. And this picture here just shows you the endocannabinoids within the brain. And these are actually what we call phospholipids. So they're fat-soluble compounds, and they're released from nerve membranes. So they're released when a nerve fires. And they're important, as I said, in normal brain structure and normal brain function. So where are these cannabinoid and endogenous cannabinoids located? Well, these are some pictures of brains of people who have had imaging using a ligand, which is something that can bind to cannabis within the brain. And the red hot spots on the left here show high levels of binding, and on the right in the sort of lighter blue. And the interesting thing related to Parkinson's is that these are areas of the brain that control movement. And so this has led on to an interest in the link between cannabis, cannabinoid receptors, and Parkinson's, because obviously we know Parkinson's primarily is a disorder of movement. So what are the normal functions of this endogenous cannabinoid system? Well, listed here is the current evidence. So pain, analgesic control, food intake. So this is why cannabinoids have been used to actually help people who are undergoing chemotherapy who lose their appetite, so-called anorexia. They can also help nausea, and particularly in people undergoing chemotherapy, that there are now synthetic cannabinoids that are used for this, and I'll tell you about that in a little bit. Cannabinoids can regulate normal body temperature. They're also important in learning and cognition, and this is really where the challenge or the potential side effect of cannabis, particularly in teenagers who use chronic cannabis, is increasingly of concern. And then finally, as I mentioned, motor control, motor coordination. There may be a role there in how we move. So as I mentioned, there are synthetic cannabinoids which have been prepared. These are pharmaceutical grade products, have gone through very rigorous clinical trials, and they're licensed for use in Canada for specific purposes. So nabilone, used for nausea, dronabinol for weight loss and nausea, both associated with chemotherapy. And then on the right, this spray that is used for pain control, particularly for people with spasticity in MS. So we do have cannabinoids that have been around for many, many years, but they have very specific licensing requirements. The real interest, I think, is what's available now. And as we're all aware that cannabis products were legalized in Canada in October 2018 for recreational and personal use. So these are either smoked, vaporized, or the cannabis oil, which contains a component of THC, CBD, or both. So this is something I'll talk about later regarding the trial that we're doing related to pain with Parkinson's. And so this really has opened up the field more and given more accessibility to these products for people, and obviously then has raised more questions, and hopefully we can perhaps try and answer a few of these today. So these are the questions that I frequently get asked, and I'm sure some of these questions will be in the questions at the end of the session. So what can cannabis do for my Parkinson's? Will it help my symptoms like tremor? What dose do I use? What type do I use? And what are the side effects? So this is where I've really started to try and understand and help people answer these questions. So I'm just going to go back again just to show you some pictures of brains where we've looked at to see where these receptors are in the brain. If you remember from the ones I showed you earlier with the human binding, these are studies that we did in experimental settings and looked at the receptors within the brain. And again, just to highlight that there are high concentrations within this area called the globus pallidus, which is critical in control of movement. And this is work that I did nearly over 20 years ago now, when I worked in Manchester, when I was doing my pharmacology PhD. And we were very interested at that time in cannabis and the role in Parkinson's disease. And so other centres, other people have also looked at this. And interestingly, if you measure the levels of cannabis in people with Parkinson's, there are actually higher levels than in people without Parkinson's. So one answer to people who say, should I take cannabis? I often say, well, you've already got lots of cannabis within your brain. There's a natural elevation of endogenous cannabinoids in Parkinson's, which may or may not be related to the disease itself. We still really don't understand that, but it's interesting that there is an enhanced level. How does it work? How does it interact with all the other neurochemicals? It's complicated, I think, is the bottom line here. But certainly cannabinoids can interact with GABA, glutamate, and dopamine, which are the very important neurotransmitters that are important in brain function. But as a result of many, many years of experiments, we hypothesized that cannabinoids could be helpful in reducing one of the motor symptoms of Parkinson's, which is called levodopa-induced dyskinesia. So these are the excessive involuntary movements that some people get when they have a little bit too high a level of dopamine in the brain. And we've done a number of experiments and studies looking at this, and certainly in labs, it shows that there may be a reduction in dyskinesia if you use cannabinoid or cannabinoid receptor agonists. So as a result of that, again, when I was in Manchester, we did a small clinical study using the drug nabilone, which, as you heard, is a synthetic cannabinoid, in a small number of people with Parkinson's, and showed maybe a very mild effect on dyskinesia. But one of the problems, and this is one of the big caveats with any cannabis, is the side effects. And in these people, there was problems with dizziness and drowsiness. And at the same time, another group actually in England used another cannabis preparation called cannabidiol, and they did a similar type of experiment and showed really no effect on their Parkinson's symptoms. So the evidence really for cannabis for dyskinesia is actually not that good, and the suggestion is it probably doesn't really have a good effect. This slide just shows you a whole series of other reports that have been published over the years looking at different types of cannabis, trying to treat a number of symptoms for people with Parkinson's, so tremor, non-specific motor symptoms. And then the next slide also shows some other trials where people have used other preparations of cannabis. The bottom line really is for the motor symptoms at the moment, there really isn't good evidence that cannabis really of any sort is helpful for tremor, stiffness, slowness, or dyskinesia. And so really at the moment, this is my recommendation, that it really probably is not helpful for these motor symptoms. And this is a summary from the American Academy of Neurology guidelines, where they put out reports looking at the efficacy and safety of products and medications in a number of neurological diseases. And in this one, they looked at medical marijuana. And as you can see from their conclusion, that there's probably, it's probably medical marijuana is ineffective in treating dyskinesia and tremor, and also dystonia, which is another type of movement that some people with Parkinson's can get. And they very rightly say that the risks and benefits should be weighed carefully, and the risk of what they call psychopathology, which is the risk of hallucinations and other cognitive problems, was nearly 1%. So in terms of the motor symptoms of Parkinson's, at the moment, really, there isn't a lot of evidence that cannabis can really help. So what about the non-motor symptoms, which is really where I think the field is going forward? And this is probably more likely to be a benefit to people with Parkinson's. So the non-motor symptoms, primarily where there may be evidence potentially, is in pain, but also the other common problem many people experience is difficulties with sleep. The challenge really is is that there hasn't been a lot of evidence in terms of studies and research to really investigate this well. Unfortunately, we don't have good models that we can look at in the lab of the non-motor symptoms of Parkinson's, unlike the motor symptoms where we do have very good models. So we can't really do these hypothesis generating studies. So what we've really had to rely on so far is sort of anecdotal and what we call case studies that really are probably a little bit biased and don't give us that good evidence. So what about the evidence for cannabis for pain? Well, in terms of how pain is caused in people, there are the models and the way that pain control, we do know a lot about that. There are many circuits involved, and certainly in non-Parkinson people, there does seem to be evidence that cannabis may be implicated in pain control. And this is targeting not only within the brain, but also what we call the peripheral nervous system. And certainly there have been studies looking at cannabinoids for pain, not in Parkinson's, but in other types of pain. And the evidence certainly suggests that there is a favor towards cannabinoids helping people with pain. And this slide is what we call a meta-analysis. So it's lumping together a number of different clinical trials. And as you can see, the diamond here at the bottom, the odds ratio is to the right, which would favor cannabinoid over placebo. So the suggestion is that cannabinoids certainly potentially could help pain. And the idea now is really, could it help pain for people who have Parkinson's and pain? So what is the evidence so far? Well, there's unfortunately very little, as I mentioned, in terms of trials for people with pain in Parkinson's. This slide and the next slide are just summarizing two studies that were done in a small number of patients with Parkinson's. In this one, they were actually smoking cannabis, and there did show to be some improvement in pain, but there was quite significant side effects of vomiting, dizziness, and also psychosis, which is the hallucinations. And then this second prior study was also cannabis either smoked or inhaled. Again, there was some improvement in the pain study, in the pain measurements. But the problem, obviously, with smoking has its own set of side effects, and there is increased risk of lung disease and even lung cancer in people who actually smoke cannabis. So clearly, this is not a way that we would recommend people to use it. So the questions that really remained unanswered are, the need for better pharmacological definitions of the types of cannabis that could help people with Parkinson's and pain. The challenge with safety and tolerability is still really a key question. And so far, no one has really done a good double-blind randomized controlled trial of a cannabinoid in people with Parkinson's and pain. So what we're doing now is starting this process. With any investigation, there usually, and this is what we're doing now, has to be a dose finding study, which is called a phase 1 or phase 2A study, where we evaluate the effect, the safety and the tolerability of a range of doses and figure out which dose may be best tolerated. And that dose then is taken into a double-blind randomized controlled trial where we would evaluate that dose of drug versus a placebo, and that will be what we call a phase 3 trial. So we're at the phase 1B early stage trials, and we're recruiting 15 people with Parkinson's who have pain, and we're giving them a preparation of cannabis which has a different combination of THC and CBD, also to determine which of these is potentially the safest, which is tolerated best, and which may give us a signal as to which preparation may help pain best, whether it's ones with more THC or ones with more CBD. And so this is the initial phase of this trial. So the next couple of slides just give a little bit more information about this. So we're now halfway through the recruitment. And if people are interested in taking part in this and are eligible, then for sure we can certainly talk to you and see if you would definitely be eligible to take part in the study. So as I said, this is really looking at the tolerability and safety of these 3 different formulations of the oil. And we're doing a number of what we call exploratory outcomes to see if there is a signal there, to see if it can improve pain using a number of rating scales. Equally, we want to make sure it doesn't have any negative impacts on the way your levodopa works. So we're doing a number of other measures to monitor for that. There are, with any clinical trial, inclusion criteria and exclusion criteria. We have to be careful that we're not including people who potentially could get side effects or adverse effects from the CBD oil. And one of the challenges with any cannabis trial is that because of the concern of sleepiness, then the person wouldn't be able to drive during that period of the study. So that's obviously a consideration to taking part if this is something you were interested in doing. One of the most important things about cannabis of any type is the potential risks and adverse events that can occur using it. And as I think hopefully you've got now a flavor of that there are so many different types of cannabis out there, that this is one of the big concerns we in the medical profession have. If you go to your local store down on Queen Street or King Street or somewhere downtown Toronto, there are many of these stores there. The problem is there's no quality control of the product that you are given. So you may walk in one day and get a certain amount of oil that they sell you as CBD oil. The next day you go in and they'll give you supposedly the same thing, but it may have a slightly different constituent to it. So this is one of the big challenges of this type of product. As a result of that, this adds to the risk and potential adverse events that people can experience. With all medical types of cannabis that I've listed here, some of the common side effects that can be experienced by people. Low blood pressure is one of the challenges with Parkinson's as well. And so this is always something that I counsel people about, that taking cannabis could exacerbate lightheadedness or dizziness. And also as a result, the risk of falling is obviously then accentuated. The big problem is the mood changes, behavior changes, the risk of hallucinations that can occur. And this is more linked to THC. But as I mentioned just now, the challenge is the ingredients that you are given in these CBD oils. It's sometimes difficult to know how much THC is in there because of the lack of quality control. And I also mentioned this risk of cognitive impairment, particularly in teenagers, and this is really of concern in the community. So this is my final slide. So I hope I've given you a little overview of where the field is with cannabis at the moment. There's a lot I think we still need to know, and a lot we need to learn. So I haven't been able to give you all the answers, but I hope I've given you some of the understanding that there is such a lot of heterogeneity and variability. And this is one of the big problems that we have in answering your question. What type of cannabis should I have? What dose? What strength? I think so at the moment, the field feels that cannabis probably doesn't have a good benefit on the motor symptoms of Parkinson's. And so I think, as I mentioned, that's not something I would recommend. But, and it's a big but, possibly there may be benefit for pain, and we'll see with our trial. Also, possibly anxiety. And I know some of the people that come to my clinic do use it for anxiety, and it can help with that. And sleep. I've not had time to really go through that as another non-motor symptom, but certainly some people have used it successfully to help them with sleep. So I think there are possibilities for cannabinoids for some of these challenging non-motor symptoms that many of you experience. And I'll stop there and we can go to the questions. Thank you very much.
Thank you, Dr. Fox. That's absolutely fascinating. And not surprisingly, it sparked a number of audience questions coming in over Slido. A quick reminder, everyone in the audience, if you have a question for Dr. Fox, go to the Slido page. The link's at the bottom of your screen. at the bottom of this live stream window. Send us your question, and you can also upvote on questions you'd like to hear answered. Remember, for privacy reasons, we will not be able to field anything of a personal medical nature. Okay, so if we can get to our first question, let's pull up the screen. Thanks, Philip. First question. Hello, Dr. Fox. Do you know if OHIP covers the cost for CBD oil?
The answer is no, because it's not an approved medication. So it's not got Health Canada approval, which is the only way that something can get OHIP coverage. So unfortunately not, no.
Can I just ask, this is something then that you or I or anybody in the audience can go and buy over the counter?
Correct. You can go into any of those stores along Queen Street or anywhere downtown and you can buy it. That's correct.
Next question. Would the same trials and treatments be available for essential tremor?
That's a good question. Cannabinoids have been investigated in different types of tremor. Again, it's a motor symptom, and there doesn't seem to be a lot of evidence that cannabis can really help essential tremor. That being said, some people feel if it helps reduce any anxiety, and anxiety can drive the tremor to get worse, then that may be a secondary effect. But no, there isn't a lot of evidence for essential tremor for cannabis.
Next question from Dennis Jones. Cannabis seems to alleviate pain associated with Parkinson's for some people, but does it interact with levodopa directly or indirectly? For example, by causing drowsiness, which might increase the danger of falls. If there are negative impacts, how can this be minimized?
Okay, yes, I mean, this is obviously an important question. There's no evidence it directly interacts with levodopa, either directly or indirectly from the studies that have been done. But for sure, it can obviously cause drowsiness. As I mentioned, that can be a side effect. And if you're drowsy, you may be at more risk of falling. So it's more the direct effect of the cannabis rather than an indirect on the levodopa. And if there are negative effects, how can they be minimized? Well, for sure, I think using any cannabinoid product, if you know you're at risk of feeling sleepy in the day, some people do find they have what we call excessive daytime sleepiness. They find they get very drowsy, then probably cannabis isn't for you. If it makes you feel dizzy, it may mean your blood pressure drops when you stand up. So making sure you're well hydrated might minimize that as an impact. But I think this is obviously a very important question with any of the cannabis products, and it's not for everybody. I think that's the key. And so just being cautious and talking to your doctor about it is important.
Next question from Ashley Brown. If PD patients have elevated levels of naturally occurring endocannabinoids, does that mean that we could benefit from lower therapeutic doses?
Good. That's a good question. And I guess it's one of the unknowns, in terms of what doses should people with Parkinson's have versus somebody without Parkinson, for example, controlling pain. And so this is the reason that we're doing our dose finding to see, is there a dose that seems to be better tolerated? Yes, unfortunately, we're not measuring endogenous cannabinoids in our trial, but that might be a way of doing it. And I think, again, this is one of those questions that we really don't know the answer to. I would say in general, with any medication with people with Parkinson's, most people with Parkinson's are more sensitive to any type of brain medication and often need much lower doses than someone without Parkinson's. So, for example, thinking of antidepressants or anxiolytics, other drugs that are used in the general community, often people with Parkinson's need a lower dose because they seem to be more sensitive. So maybe that's just a general principle that with the cannabinoids, it may be that the lower end of the spectrum of dosing might be more better tolerated, should I say.
All right, from Gordon Myers. He has two questions, actually, Dr. Fox. How does the mode of delivery, smoked, vaped, eaten in cookies or in oil, and THC content of the cannabis from none to maximum affect the outcomes for chronic pain? I can add on the second question here if you want to address them both at the same time. Have you been surprised to find any other symptoms that improved with CBD and or THC use?
All right, Gordon, lots of questions there. I actually probably haven't got all the answers for you because we don't know. And I hope that was sort of the theme of some of what I was going through in my slides today. We don't know whether the mode of delivery makes a difference. And again, just to emphasize, there's so much variability and there are so many different types of cannabis in the smoked and the vaped versus perhaps that's in the oil. So it's more the type of cannabis than the way it's delivered, I believe, is the difference there. But I think, individuals I know have used smoked, vaped, oral, and some people say it helps, some people say it doesn't. So there's obviously a lot of heterogeneity in people's responses. The THC content, that's an unknown, and this is why we're doing the trial. And I hope that we can answer partly that question with our trial where we're looking at different THC content. So I think that's something that we hopefully can help answer. Have I been surprised about other symptoms? Surprised, I mean, I think predictably, I think sleep for sure. A lot of people do report to me that they've used different types of cannabis and it can certainly help sleep and anxiety. I would emphasize that again. A lot of people have found it can help reduce anxiety, which I know for many people with Parkinson's is a challenging symptom. I don't think I've heard of anything that's sort of not within the spectrum of symptoms that I would expect cannabis to improve. Maybe Gordon, you can let me know offline other ones that you were thinking of.
Fair enough. Next question then from Lorena A. Can you speak to the difference between CBD, CBG, CBN, and whether these are being studied in relation to PD?
Lots of acronyms, yes. I'm not quite sure what CBG and CBN, what you were asking, what subtypes. I mean, they're probably just the different subtypes of the cannabis pharmacology. Yes, I think, again, an unknown question. We don't have subtype specific therapeutics to test all of these different subtypes in models. The ones that we've tested, going back many years in models of Parkinson's, were very, very selective, what we call CB1 agonists, rather than the product itself. So I think the answer is we don't know the difference, and at the moment they're not being studied in Parkinson's, to be honest. So maybe in the future, but at the moment, no.
Next question from Mario Cordero. Very interested in volunteering for your trial. How do we volunteer?
Good question. So if you are a patient in our movement disorder clinic, that's easy. You just speak to your physician who you see here, and they'll forward your information on to me. If you aren't a patient here at the clinic, you are more than welcome to ask one of your physicians or healthcare providers to send in a request to me here at the Movement Disorders Centre, and I can check that you would be eligible and suitable, and then we can get back in touch with you. That's fine. Yeah.
I'm not sure if we need to drill down there, Dr. Fox, but is there a particular phrase or the name of the trial that they should use?
They can just say for the attention of me, Dr. Fox, at the Movement Disorder Clinic, regarding the cannabis trial. Simple as that.
Very good.
Very easy, yes.
All right, next question. How do we know how much to take, starting doses, and increasing/decreasing if necessary?
Well, this is the reason we're doing these trials, because we don't know those answers. And I often get asked this question. If people really want to start now without waiting for the evidence, I would say to start low and go slow, which is usually the usual recommendation with any medication. So if you're going to want to use this, the lowest amount at night, would be my suggestion, and at night, just in case it makes you feel sleepy, drowsy, groggy. And then just very, very slow titration. But again, this is the reason we need the evidence and the trials, and this is why we're doing this work, to try and answer these questions better.
Absolutely. All right, next question. What other studies are happening internationally around this topic? And is Canada a leader in the field because of recent legalization?
Well, there are many studies going on around the world, because cannabis has been legalized in many other parts of the world. And there are countries that were legalized prior to Canada, for example. So places like Israel are leaders in this field, for example, and some states in the United States have also been leading this as well. So it is happening internationally. We in Canada are obviously trying to keep ahead of the field, and really what we really want to do is provide good quality evidence. I think that's the challenge, and that's what we're really trying to do. There is now a group of academic researchers that have come together across the University of Toronto, who have an interest in cannabis from many fields, so pain, psychiatry, neurology, community epidemiology. So there is a large now group of researchers that are looking at ways of trying to improve the evidence for use of cannabis in Canada. So it's certainly an area that's increasing in hopefully knowledge, expertise. People are coming together to try and answer many of these questions.
Next question from Gabe. What cannabinoids, again, the acronym CBD, CBG, THC 500 plus, are the most effective for treating rigidity?
Well, again, I seem to be a broken record here. We really don't know. From the work that we did in the early years, looking at the motor symptoms of Parkinson, which rigidity is one of those, in models of Parkinson, it's probably the THC component that's probably the most effective in rigidity, if I was going to pick one of those. The challenge, though, with that is that it obviously has far more side effects potentially for someone with Parkinson than the non-THC components. But that probably, from the preclinical evidence, is the one that's perhaps got the most benefit. But again, we haven't really gone through, as you said there, 500 plus. That's, there are many different types, and not each individual one has actually been evaluated in a good model system to know. The spray cannabis that I mentioned, that's approved for MS spasticity, is a mixture of CBD and THC, but spasticity and rigidity are actually slightly different. The muscles are both rigid, but the cause of that rigidity is a little bit different. And so that's as I said, approved for spasticity in MS, but rigidity in Parkinson's, possibly THC.
Next question. Can a person with PD still drive while taking THC at nighttime? Also, what is the legal side of having THC or CBD in the blood and driving?
Good questions. Yes. Obviously there's a risk of any brain altering drug, if you like, when you're driving. I would say being very cautious. Any of these drugs could effectively make you fall asleep. That's obviously a concern. At the moment, there's as far as I'm aware, there's not a caveat with, there's not a legal precedent set with THC particularly. I'd have to look up what the driving and cannabis laws are at the moment, unless, Christian, you happen to know. I'm not sure myself.
Are you inferring I'm an expert on
No. I'm just asking any of the group here if anyone's
sorry, no.
no, I'm only joking. I don't know. But to be honest, I'd have to get back to whoever that is. I don't know the answer to that question. Yeah.
All right, fair enough. Next question. How is this type of work being funded? Is it controversial from a political stance to get grants? And do you have the resources you need? Now, there's a great question.
That is a good question. We always need more resources. Research costs a lot of money, unfortunately, but it's important to obviously do it. This particular study fortunately has been funded by a small pilot project grant from Parkinsons Canada. So Parkinsons Canada helps with these small grants just to get projects off the ground. But what we would like to do is, once we have this phase 1B 2A data, is then to develop a phase 3 double-blind randomized controlled trial, which we would then submit to a granting agency to get funds to perform the large definitive phase 3 trial. I think at the moment, Canada, in terms of granting agencies, that the political stance is not, I don't think it's controversial. If anything, I think there's an interest and a desire and a hunger to really get better evidence for the use of cannabis. And I'm hoping, government funding agencies are going to be sympathetic and interested in funding these. But absolutely, we will be looking for further assistance with funding these trials going forward.
Is there an age requirement for participating in the trial?
The only age requirement is over the age of 18, because we really want this to be in adults and not younger than 18. Again, I'll emphasize, this long-term concern about teenagers' brains and cannabis. And so we wouldn't want to expose anyone under the age of 18 to a cannabis product, even though it will be for a small period of time. And so, yes, over the age of 18.
Can CBD oil be used for PSP? Does the oil have to have THC?
That's a good question. So for people who aren't familiar, PSP is progressive supranuclear palsy, which is a type of Parkinson, but it causes other symptoms, particularly difficulties with eye movements and speech and balance and walking. There hasn't been any evidence, there's not been any trials specifically in PSP. That being said, if people have sleep issues or pain associated with PSP, and we can show from the Parkinson trial that there's a certain type and dose that's safe to use, then that may be reasonable to use. Again, we don't know whether CBD or THC predominant oil is going to be better or not, or better tolerated or not. So I think, again, that's a question we'll have to park to one side for the moment.
Next question. What about topical CBD THC ointment, i.e. not ingested? Does this have a positive effect on pain, stiffness?
Yes. Some people who come to my clinic have used it. Again, there's no trial data, there's no evidence-based medicine reports to know if it does or not. Obviously, it's not going to cause any side effects of ingest. You're not going to get the risk of the sleepiness, dizziness, but how much benefit it gives, I think that would just come down to an individual's use of it.
Next question. Were there any observed issues regarding change, worsening of cognitive function, or exacerbation of psychosis syndromes with THC preps in PD patients?
So the answer is yes, unfortunately. With the THC, which is the psychoactive component, then for people who are at risk of developing hallucinations, for example, that was something that has been described with THC in people with Parkinson. Grogginess, sort of head just not being able to think straight, that type of sort of cognitive change has also been described. And so this is obviously one of the potential challenges and side effects of using cannabis products in people with Parkinson. Is it a problem longer term? Well, we don't really know, but this is again something that we really need to get better answers to. But because of the risk of THC causing hallucinations, this is something that I always very carefully talk to people about if they're interested in wanting more information or wanting to try cannabis preparations, that this is always a concern and potential risk. So just to be extra careful with it. Yeah.
Next question. Do you have any research going on in Canada for hydrogel? Please let us know if it is safe and will be available soon. Thanks.
Yeah, I'm not aware of any. As I said, there are many researchers that are now looking at different types of cannabis in many different conditions in Canada. I'm not aware specifically of hydrogel, so can't answer that question, unfortunately.
Not to worry. Next question. Great information. Thank you. Also interested in volunteering for the trial. How long will it be conducted for? When are you expecting the results?
Well, we're about halfway through, so we'll be continuing to recruit people from now, and I hope we'll have finished recruitment by the spring of next year. And so I'm hoping by end of 2022 or even earlier that we'd have results by then. And then, as I said, what we plan to do, assuming that we have a dose and a preparation that seems to be the best combination to take forward, then we will be planning our phase 3 trial to go ahead after that.
Fantastic. Can I also ask, perhaps for people thinking of volunteering, if you have no prior history or experience with THC cannabis, is this still something for them certainly you would recommend they try?
Well, if they're interested in, yes. And in fact, if people are actively using some type of cannabis, we would ask them to stop to do that for at least 30 days anyway, because we want people to not have anything sort of biasing or contaminating the study. But no, if people are cannabis naive and wish to take part in the trial, which most of the participants, I have to say, so far that have taken part were, then that's absolutely fine. Absolutely fine. Yeah.
And that leads well into our last question. Thank you, Dr. Fox. Can you point us in the direction of some resources to learn more about CBD PD?
So the websites that are part of the Parkinson Foundation in the US, the Michael J. Fox Foundation, Parkinsons and Canada, all have information about cannabis and Parkinson's. We have something on our UHN Movement Disorder Clinic website as well. Those are probably the most informative and educational resources. You do need to be careful about what's out there. There's a lot of misinformation and myths. So, as I said, just be careful and talk to your healthcare provider, your doctor, about it as well. They may also be able to direct you to some resources.
That's terrific. We really appreciate you taking time out of your busy day, Dr. Fox. This is a first in terms of these live streams. We actually got to every question, which is amazing. Thank you for your efficiency, and we get to let people go a few minutes early today. I want to thank you, Dr. Fox, Associate Director of the Edmund J. Safra Program in Parkinson's disease and the Morton and Gloria Shulman Movement Disorders Clinic. Thanks so much again for joining us.
Well, thank you.
I also want to thank Dr. Tony Lang, who had to leave us, but was with us earlier today. He's the director of the Edmund J. Safra Program in Parkinson's disease, the Morton and Gloria Shulman Movement Disorders Clinic, and the Rossi Progressive Nuclear Palsy Center. We always, a pleasure to have Dr. Lang with us in these broadcasts. So that's brings us to a close for today's Movement Disorders virtual Q&A. As always, we want to thank our audience for joining us, and we'll be returning with another edition of the Movement Disorder Virtual Speaker Series in spring of 2022. So keep an eye out on your email inbox. And this event has been recorded, so it'll be available on the UHN Foundation YouTube page right after this live stream is over. And finally, if you're able to donate to the Movement Disorders Research Program, you'll find a link at the bottom of the streaming window that will direct you to our donation page. And your support is very much appreciated. And as you heard from Dr. Fox, it's always needed when it comes to funding trials and investigational research to be able to show whether these investigational products will work in terms of helping with pain with movement disorders. Thanks for tuning in. Keep practicing physical distancing. Continue to mask. And if you haven't done so already, please get vaccinated. Thanks for joining us.